Vishal, shall we start?
Yes, yes, yes.
Uh, uh,
A-
yeah,
Amita,
Shreya,
are you
let's start.
ready?
Yes, sir.
Amita? Yes,
Yes, sir.
okay, okay. That's fine. Yeah, thank you. Kunal, you can go ahead. Yeah.
Yeah, Shreya, we can start.
Yes, sir. So, good afternoon and a warm welcome to all the dignitaries present here. I'm Sreushi from Clanet, serving as the allocated session assistant to ensure a seamless experience. Clanet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clanet serves as the digital partner for this event hosted by the National Neonatology Forum Gujarat, and the focus of today's session is case presentation extreme low birth weight. So let's begin today's session, for which I would like to invite Dr. Kunal sir to take over. Over to you, sir. You can proceed now.
Thank you so much, Shreya. Uh, since you all know that we have our Neonatal Pathshala series going on every Wednesday between 3 to 4 p.m. And today we are having an case presentation. We have different topics which we cover in our Neonatal Pathshala series. So today we will be taking a case presentation. And we are having a very interesting case on extreme low birth weight baby. For that, Dr. Amita is there. Thank you for presenting the case. And we have as an expert, Dr. Manjuna. Thank you so much, sir, for accepting our invitation and being a part of our Neonatal Pathshala series. Thank you so much, sir.
My pleasure.
Uh, without wasting a minute, I would request Dr. Vishal to kindly introduce the expert and the presenter, and we'll continue with our case presentations.
Thank you, Kunal. Today we are going to have a session regarding the case presentation, and for that we have a presenter, Dr. Amita. Basically, she is MD pediatric from the I think Udaipur, and followed by she joined as a neonatal fellow at Setu Newborn Care Center, which is one of the renowned center in Ahmedabad. If I talk about the neonatology, so I welcome Dr. Amita. And for expert, we do have a Dr. Manjunath from the Bangalore. He's one of the good friend of mine. He's a neonatal consultant from the Rainbow Children Hospital, Bangalore. He did the MBBS and the BCH from the Mysore Medical College, Mysore, and followed by he did the MRCPCH and FRCPCH from the UK. And he is practicing the neonatology in the UK, I think more than the 10 to 15 years. He's also like director of the newborn life supports course in UK. Like we have NRP in UK, we do have a NLS course. He's also instructor for the ARNI, which is the Advanced Resuscitation of a Newborn Infant. It is one of the, I would like to say, one of the great course if I talk about the neonatology, which is 3 days course. And I think those who are getting the chance in the future, I think everyone has to attend that ARNI course. Of course, I attended with the Manju, I think, before 3 years. He's also like cardiology for neurology faculty in RCCP CH. Also like faculty of the various neonatal hemodynamic workshop, focus, and also MRCPA CH examiner. He's also like member of the various organization around the India, like FRCPCH UK, like a fellow of the Royal College of Pediatric and Child Health, British Association of the Perinatal Medicine in India, NNF and Indian Medical Counseling, Karnataka Medical Counseling, etc. He's also like have a like multiple publication and paper presentation around the world, specifically in the European country, European journal, and the archives of the children, archives of the disease in the childhood. And also, he has a multiple presentation regarding the hemodynamics, specifically like PPH and ultrasound related things, and a neonatal cardiac emergency. So, thank you so much, Dr. Manju, to accepting our invitation in short notice. And we'll start the session. And as we discuss, you can ask the question in between them, and we can carry on with the discussion. Thank you so
Thank
much.
you. Thank you for the kind introduction. Thank you. Looking forward for this presentation.
Yeah,
Thank you.
yeah. Amita, you can now share your screen and start the case presentation.
Sir, is my screen visible?
Not yet.
Amita, you have to select the green button, that is the share button, and
Yes, sir.
then you have to select the PPT screen.
I think if you open it first, and then it should come under, once you click on the green button, it should also come up with that. Amita, thank you.
Now
Good.
we can see.
Now we can see.
Okay. Thank you, sir. Good afternoon, everyone. I am Dr. Amita Himes. I am currently a fellow at Setu Newborn Care Center. Today, I am going to present a case on a baby of XYZ, the single child, female, born at 25 plus 2 weeks of gestational age with a birth weight
Amita, we
of...
can't see your
Next
presenter
slide.
mode actually. So, if,
Can you go for
Can
slide
you-
presentation?
slide presentation
Is it visible, sir?
visible, but it's not a presenter mode, I think. But we can see, Manju, am I right? If it's all right for
And
you.
what you can do is, you on the top there are written file, home, insert. There is a slideshow option is there. Yes, your arrow is there. Left to that, there is a slideshow option is there.
Like near the animation.
Above that. Yeah, above. Yeah, on the right hand side. Now on that same line, go through the towards the right. There is an slideshow.
Slideshow.
Yeah, and now below there from beginning. Yes, click on that.
Is it fine, sir?
No.
It's not visible.
Ma'am, you can do one thing. You can stop share and share once again. Try that.
Okay.
And select the full screen option. There will be two options, one with the this thing smaller one and the one with the full screen. You can start from the full screen one.
Okay, sir. Okay. Is it visible, sir?
Yes, now
Yes.
it's visible.
Okay. So today I'm going to present a case of a single female born at 25 plus 2 weeks gestational age with a birth weight of 560 grams, delivered by lower section cesarean section in view of prom with severe oligo on 18 September. Currently, the baby is 34 days, that is 30 weeks on HHFNC support. Antenatal history: a 30-year-old G4A2L1 female conceived spontaneously in a non-consensuous marriage, was booked at a private hospital at 8 weeks of gestation. Periconceptional folic acid was taken. There was no history of rash, fever, bleeding, or hypertension. She took iron and calcium supplements in the second and third trimester. 2 doses of TD were taken. She is a case of gestational diabetes mellitus, currently on insulin, and a known case of hypothyroidism. Anomaly scan done at 20 weeks of gestation was normal. Doppler scan was done prior to the delivery, which was normal. She was admitted in view of PPROM at 72 hours prior to the delivery. Blood investigations were sent, which revealed a CRP of 48 milligrams per liter at 48 hours prior, and antibiotics were started for the same. She is negative for HIV, hepatitis B, and VDRL. Labor and delivery details: 2 doses of betamethasone were given. LSCS was done. Postnatal history: the baby did not cry at birth, so delayed cord clamping could not be done. Baby was received in a plastic wrap. Initial steps of resuscitation, including intermittent positive pressure ventilation by bag and mask, were done. Baby was intubated at birth and transported on a transport ventilator to our unit. Apgar score at 1 minute and 5 minutes were 4 and 7 respectively. NICU care at admission. On admission, baby was taken on a mechanical ventilator. Parenteral nutrition and trophic feeds were started. After sending blood culture, IV antibiotics were started in view of PPROM and maternal high CRP. Respiratory system: the baby was on mechanical ventilator at the time of admission.
Dr. Amita,
Yes, sir.
thank you. Shall we stop here and just have a chat, about antenatal and perinatal and then move on to the system? Is that okay?
Yes, sir.
Okay, now, just going back with few of the slides. So you said 25 plus 2, 560 grams. Is that right?
25 plus 2, 560 grams.
Okay. And you said there was a premature prolonged rupture of membranes.
Yes, sir.
Mother was not in labor, but she had a rupture of membranes. Is that right?
Yes, sir. Yes, sir.
Okay. And how many days before delivery she ruptured membranes?
So 3 days before, around 72 hours before the delivery, she TPROM occurred. For the same, she went to the hospital where they admitted her, and then the blood investigations were sent.
Okay. And you commented about the oligohydramnios, severe oligohydramnios. Is that right?
Yes, sir. Yes, sir.
And when were the last scans done? And do we know any previous scans done to that? When did they pick up the severe oligohydramnios? Is that important?
Yes, sir. They picked it up on the last scan done prior to the delivery at around 22 weeks.
At around?
At around 25 weeks.
Okay, so 2 days before it was done, and it was. Why is it important? Severe oligohydramnios. How does it affect the fetus?
So severe oligohydramnios will affect the growth of the baby, and Doppler changes may occur which need to be checked.
Sorry, what needs to be checked, Dr. Amit?
Doppler changes may occur, sir, because of oligo. Also, the lungs may have issues. Hypoplasia may occur.
Okay. Okay. So if there is a oligohydramnios or severe oligohydramnios, the lung can't grow properly. Is that what
Yes,
you are
sir.
saying?
Yes,
Because
sir.
there should be some breathing movements. If that does not happen,
Yes. Yes,
the lungs
sir.
will not grow properly. Okay. And what other things makes us to think mom could have been in labor? Any other things you would have asked for?
So we will ask the detailed history, whether she had any pains, whether there was any history of fever, or any history of rash, or lower abdominal pain.
Okay.
And along with that, if there are any other risk factors, fever, tenderness.
Okay. Okay. Yes. So what are those some of the symptoms of chorioamnionitis you are trying to establish? Is that right?
Yes, sir. If the mother has a fever, lower abdominal pain, or uterine tenderness, fetal tachycardia, then we'll suspect chorioamnionitis. And since the blood investigation showed a raised CRP, along with that, if leukocytosis is present, that also indicates chorioamnionitis.
Okay, so there was leukocytosis. And mother can also have tachycardia and tachypnea, and she can also appear unwell. Is that right?
Yes, sir.
Okay, okay. Now, just you were not there at the time of birth, were you?
So we attended the delivery.
So you were there at the time of delivery. So
yes,
just
sir.
Tell us a bit more how you manage extreme preterm babies at birth, or in what way is it different?
So first of all, sir, we prepare our team. We ask the gynec certain questions, and after we know the detailed history of the child, then accordingly we'll prepare. We'll from thermal protection, like starting the warmer, ensuring because the baby is preterm, we'll take the baby in a plastic wrap and immediately place the baby under the warmer.
Okay.
We will not dry this baby. We'll directly wrap the baby, and then sir, we'll position the baby properly and start initial steps of resuscitation.
So you talked about a good thermal care, and do you know what generally you want to keep the temperature of the labor ward or the delivery room for extreme preterm babies?
So 26 to 28 degrees.
Okay, good. So at least around 26 degree has to be there, and plastic wrap is good. Anything else you would do along with plastic wrap?
So we'll ensure the head is properly covered.
Okay, it is also properly covered. Okay, good. Yeah, so that's about the thermal care. So that has to be a continuum of thermal care. What other measures you take at the time of birth for preterm babies, which could be a bit different from term babies?
Sir, delayed con clamping is not done
Yes.
because
Because
usually.
the baby was not crying. Is that right?
Yes, sir.
What
Yes,
other
sir.
parameters would help you to decide whether you need to cut immediately or not?
Sir, if there are any other complications, placental complications like placenta previa, or the gestational age is very low, twin gestation.
Okay, yes. So if you are worried about twin transfusion syndrome, probably you don't want to. Or if you are worried about if there was any abruption, and if you're strongly suspecting that's the fetal blood loss happening, you don't want to. But in terms of your clinical assessment of the baby, does all baby cry at birth?
Uh, Most babies will cry, sir.
At birth? Yes, maybe term, but even up to 1 minute or even 2 minutes is okay if they don't cry. So, what other parameters generally help us? I know probably this baby was not an appropriate, but I'm generally asking what other parameters will help you to assess whether you need to clamp now or you can delay for some more time.
So the color of the baby, the tone of the baby, whether the baby is breathing or not.
Okay, so the color of the baby would help you. What color you would be worried about?
So the baby is completely blue, the center as well as the periphery is blue, then we'll be worried.
You'll be worried. What color are the babies when they are born generally?
So usually the center is blue, the periphery is center is pink, the periphery is blue.
Okay.
In most cases, when
Maybe
the baby cries.
okay. Maybe just good to for you later to think about it because what is the normal fetal saturation you think, generally speaking?
So at birth in the first minute, we expect 60 to 65%.
Okay. So what color would that be if somebody has got 65% saturation?
Blue, sir.
Okay. So you would not be generally worried about blue. So then what other color you are worried about? So babies can have three colors generally, isn't it? Blue,
Yes,
pink,
sir.
or
Purple.
yes, or
Purple color, sir.
white. They can be white. Have you seen pale babies?
Yes, sir.
Okay. So you would be worried about pale babies, isn't it? More of.
Yes, sir.
What does pale indicate?
So antepartum hemorrhage or accidental hemorrhages or a poor circulation.
Okay. So either it should be blood loss causing anemia, or it could be acidosis causing severe vasospasm, vasoconstriction, giving that pale appearance. Okay. So that's one you said about the color. You said about the baby breathing. Okay. And you also said about the baby's movement. What does
Yes.
baby's movement indicate?
So the tone of the baby, if the baby is limp, then that indicates the child needs resuscitation. If there is active movements present, then we can go forward with DCC.
Sure. So, it's good to use all of those parameters at the time of birth to make a decision whether a delayed cart clamping is possible or not. I'm not speaking particularly for this baby, but generally at the time of birth. So, if I say if there was a baby who did not cry, but had a good tone at some moments, and you see the baby is blue, huh? And if you are somebody had a sterile towel, if it was a C-section, or if it was a vaginal delivery, if somebody listens to the heart rate more than 100, would you clamp immediately if the baby is not crying, or are you happy to wait?
No, sir, we will wait.
No. Okay. Okay. So
Yes.
it's good to assess all of those parameters and get a feel what's happening. And some of the obstetricians are also very good. As soon as the baby is born, they try to wipe, stimulate, and sort of things. Okay. But anyway, so this baby needed to get into the plastic bag. Okay. And in terms of resuscitation things, you started on positive pressure ventilation. Is that right?
We started at the initial steps, sir. We first we positioned the baby dry, stimulated the baby, and connected the baby the neopuff T-piece resuscitator.
Okay. Okay. And any particular NRP recommendation, what pressure you want to use or what auction you want to use for a 25 weeker?
Sir, PWEP of around 5, and we'll start with an oxygen saturation of around 30%.
So you mean FiO2 or 0.3 or oxygen of 30%. Okay,
Yes.
yeah. PEEP of 6. Okay, is that
Yes,
what
sir.
the baby required, or did the baby require some positive pressure ventilation as well, not just the PEEP?
So the the heart rate improved after IPPV, but the saturation was not maintained, which was why we needed to go further with intubation.
Okay. Now, what was the top pressure you used? PIP?
22, sir.
22. Okay. Do you know what is NRP recommendation, generally speaking?
Around 20, sir, we should use.
Okay. Have a look. In UK, in NLS site, we would have said 25, 24, 25. But you have to assess the baby's chest wall movement as well and then make the decision, is that right? Do you need to come down? Or sometimes you might have to go up a bit. What is the worry here with the ventilation?
So the baby was not maintaining saturation.
Okay. No, what I meant is, Dr. Anita, while you were resuscitating an extreme preterm baby,
Yes, sir.
do you use low pressure then for term babies or high pressure then for term babies?
So we'll use less pressure because we're worried about trauma to the lungs, barotrauma, atelectotrauma.
Okay. Yes. Because we are worried because the chest wall is so compliant, it expands. The chest wall compliance is very much. Doesn't make sense? Yeah.
Yes, sir.
Okay. So you want to use the low settings of the pressure compared to the term baby. Okay. And then with that one, you got good chest wall movement, but you needed more oxygen. Is that right? Is that what you
Yes.
said?
Yes, sir, there were chest wall movements, but the oxygen saturation wasn't coming up as
Okay.
required.
And where do you put your saturation monitor?
So preductal in the right upper limb.
Okay, okay. And do you remember your NRP recommendation of the saturations? How much you want to?
So in the first minute, 60 to 65%. In the second minute, 65 to 70. In the third minute, 70 to 75. Fourth minute, 75 to 80. And by around 10 minutes, we expect 85 to 95.
Okay, so by 10 minutes, we should be around 90. And if you are more than 95, definitely you need to reduce the oxygen. Okay, so
Yes.
Afghar at 1 minute was 5, and then it was 4 and 7.
Yes, sir.
Oh, at 1 minute and 5 minutes was 4 and 7 respectively. Okay, yeah, thank you. And what was the temperature? Do you check temperature in the labor ward?
So we would place the child under the warmer and we'd set a target temperature of 36.5 degrees.
Okay. Okay, and you could achieve that?
Yes, sir.
Good. Because why is temperature so important?
So because if the child is cold, then heat loss occurs, which increases the chances of mortality. Around 28% mortality occurs if the temperature is 1 degree Celsius lower than needed. For every 1 degree Celsius lower than needed, chance of mortality increases around 28%.
Good. Okay. So it's a paramount importance of maintaining the temperature, and as you said, having a saturation monitor so that we are not hypoxic, and also we are not hyperoxic. Yeah. So
Yes, sir.
most important couple of those things. Okay. Good. Okay. Do you use anyway monitoring of CO2 in the delivery suite?
No, sir.
No, I think in most of the units, even in Western units, currently it's still in a more of a steady phase to use end-tidal CO2 from labor ward as well. So yeah, thank you. Okay. So that's about the resuscitation bit. Okay, carry on.
Yes. Now the NICU care. Can I start, sir?
Yes.
Okay. At admission, we took the baby on a mechanical ventilator, and parenteral nutrition and trophic feeds were started. After sending the blood culture, IV antibiotics were started in view of PPROM and a high maternal CRP.
Okay.
The respiratory system, as mentioned, the baby was on a mechanical ventilator. Chest X-ray was performed, which revealed findings of RDS. 2 doses of surfactant were given and the baby was extubated by day 6 of life. Post extubation, baby was taken on CPAP on PEEP of 6 centimeters of water and FiO2 of 40%. Currently, the baby is on high flow nasal cannula on a flow of 3 liters per minute and FiO2 of 28%.
Okay. And currently the baby is 34 days. Yeah.
Yes,
So
sir.
5 weeks.
Yes, sir.
Okay. So around 30 plus 2 weeks. Okay. Yes. Yeah.
Cardiovascular system. 2D echo was performed at 24 hours of life, which revealed a TR jet of 1.8 meters per second, a moderate PDA with a pulsatile pattern, left to right shunt, and LAAO ratio of 1:1. The PDA was of a closing pattern, so no treatment was initiated, and follow-up echo showed closure of the duct. On day 25 of life, in view of increased episodes of apnea, blood investigations were sent. The baby's hemoglobin was found to be 6.3 grams per deciliter. There was no evident signs of bleeding, and neurosonogram was done to rule out IVH. Post that, one TRBC transfusion was done. Sepsis workup. As mentioned, after sending the cultures, IV antibiotics were started. Initial CRP was negative, and the antibiotics were stopped after a negative blood culture and 2 negative CRPs. GI. Trophic feeds were started at admission. The feeds were gradually increased as tolerated. Protein was started at 2 grams per kg per day and increased to 3.5 grams per kg per day. Full feeds were reached on day 7 of life. HMF fortification was given on day 14 of life. Iron, calcium, and vitamins were given. Currently, the baby is on full mother's milk given via nasogastric tube at 180 ml per kg per day with HMF and supplements. The total energy intake of the child is 121.5 kilocalories per day, while protein is 3.7 grams per day. Hyperglycemia. On day 12 of life, the baby had a high blood glucose, which was confirmed by 3 consecutive readings of more than 500 milligrams per deciliter. Thus, an insulin infusion was started. The infusion was weaned and stopped by day 20 of life. Currently, the baby has normal blood glucose levels. Neurology. Neurosonogram was performed as per a unit protocol on day 1, 7 and prior to the PRBC transfusion, which revealed normal findings. Summary of the history is an extreme preterm baby, 25 plus 2 weeks, extremely low birth weight with intrauterine growth restriction, infant of a diabetic mother, respiratory distress syndrome, hyperglycemia, anemia of prematurity. Examination. The baby was nursed under a servo-controlled radiant warmer with a set temperature of 36.5 degrees Celsius. The temperature probe was attached to the right lower part of the chest. Baby was placed in supine position with cap and nasal prongs connected to the high-flow nasal HHFNC with a flow of 3 liters per minute and FiO2 of 28%. Baby's vitals are pulse rate was 144 per minute, regular with adequate volume. The respiratory rate of 48 per minute, thoraco-abdominal type of respiration. Capillary refill time was less than 3 seconds. Baby had pink extremities, a temperature of 36.6 degrees Celsius, and a saturation of 94%. Anthropometry. At birth, the baby's weight was around 0.56 kgs. Currently, the baby's weight is 0.85 kgs. The length of the baby was 29 centimeters at birth. Currently, it is 34 centimeters, and the head circumference was 21, which currently is 24. Head to toe examination. The anterior frontal was open, approximately 1 × 1 centimeters. The posterior frontal and sutures are normal. Eyes were normal. Bilateral red reflex was present. Ear, nose, and mouth were normal. No cleft lip or cleft palate was seen. Skin was normal for gestational age. The back, spine, and genitals were normal. Central umbilicus and a patent anal orifice was noted. Systemic examination, respiratory system. The baby is on HHFNC with prongs fixed appropriately and leak audible. Baby is on a flow of 3 liters per minute and FiO2 of 28%. The baby is comfortable with an RR of 46 per minute. Has minimal intercostal retractions and a preductal oxygen saturation of 94%. On auscultation, air entry was equal on both the sides. Cardiovascular system. The baby is pink with a heart rate of 144 per minute with peripheral pulses palpable, regular rhythm and normal volume. The femoral pulses are palpable bilaterally. CFT is 2 seconds at the sternum and peripheries are warm. Apex impulse was located at the fourth intercostal space, medial to the mid-clavicular line. Heart sounds are normal. No murmur was present. End organ perfusion was good as noted as a urine output of 2.3 ml per kg per hour. GIT, the abdomen was soft, non-distended. CNS, baby is alert, active, with crying intermittently. Posture, the bilateral lower limbs were flexed and upper limb was slightly abducted. Tone, active tone, pull to slight resistance was present during the initial stages. Passive tone, scarf sign, the hand was crossing the midline. Popliteal angle was around 150 degrees and the heel was touching the ear. Power was more than 3 or 5 in all four limbs. The grasp reflex, rooting reflex, and partial motor reflex were present. Detailed cranial nerve examination was not performed as the baby is premature. Summary, an extreme preterm born at 25 plus 2 weeks with extremely low birth weight of 560 grams. Infant of a diabetic mother, born in view of PPROM and severe oligo, intubated in view of poor respiratory efforts with severe RDS, requiring 2 doses of surfactant, with hyperglycemia requiring insulin and anemia requiring a PRBC transfusion. Currently, baby is 34 days old with post-menstrual PMA of 30 weeks on full enteral feeds with HMF fortification and HFNC support with flow of 3 liters per minute and FiO2 28%. Thank you.
Thank you, Amita. We can go back with some of those slides. So this baby hearing through has done really well from being born at 25 weeks. In terms of your respiratory system, have you got, in terms of the investigations to show some X-rays or anything?
So currently in the presentation, I have not attached any images.
Is it? Okay. Now, where did you give the surfactant? Was it after the baby was brought to your unit? Is that right? Or did you give it in the previous in the labor ward or in the other unit?
So after we transported the baby, after in our unit we gave the surfactant.
Okay. And what is your normal practice?
So usually either based on clinical.
What helps you to guide you when you want to give the surfactant?
So we usually administer early surfactant based on the FiO2 requirements, or if FiO2 requirements are minimal, then after a chest X-ray.
Okay. What do you mean by minimal support or any? How do you
so 30%.
quantify that? Huh?
So around 30%. If the requirement is more than 30%, then in a preterm baby we consider surfactant.
If the oxygen requirement is 30% or above, you would consider the surfactant.
Yes, sir. With optimal pressure settings.
With optimal pressures. Okay. Yes. That's more. What are the different means of giving surfactant? Do you know?
Yes, sir. INSURE technique, LISA technique, MIST. And currently they are even trying nebulization.
So currently there is also talk about nebulization, but that hasn't been to India. I haven't come across, or even in Western countries, few teams have started as more of still in the trial process. Okay, yes. Now what surfactant did you use for this baby?
So we use NeoSurf.
NeoSurf, okay. And now, in terms of giving surfactant, what you said, is it for ventilated babies or is it more for CPAP or NIPPV babies? CPAP
so
babies.
These techniques are for babies who are on CPAP or NIPPV. Intubated babies directly through the ET, we can give surfactant.
Okay, yes. And there are different. Have you come across different means, terminologies, prophylactic versus rescue surfactant or early
versus?
Yes,
prophylactic surfactant isn't recommended.
Yes.
We can give early and rescue surfactant, but prophylactic is usually not advised.
Not advised, okay, yes. Because that used to what happened in the past, but nowadays, even that is not helpful from that point of view in terms of morbidities. So we have moved away from we have moved away from prophylactic surfactant. So here what the baby had was rescue surfactant, rather probably early surfactant.
Yes,
generally, do you know what hours or anything they use for early?
Sir, 30 minutes to 2 hours.
Okay. Yes. Yeah. Okay, so less than 2 hours is considered as early surfactant. And advantages of early surfactant versus late?
So early surfactant will reduce requirement for ventilatory support in the future.
Yes.
A requirement also is reduced, and
The chances of air leak, all of that would be reduced if you are going for early surfactant. And as you can imagine, the alveoli might start to collapse. Yeah.
yes, sir. Yes, sir.
Oh, okay. So what you're trying to do is open up the alveoli. Yeah.
Yes,
And
sir.
so you went for early surfactant, and you remember the dose
Also, we give by 5 ml per kg.
of
5
Neosurf.
ml per kg of Neosurf.
How much is that? Surfactant milligram per kg?
100 mg per kg.
Is it okay? Generally, have a look how much is there in Neosurf. I too have forgotten about it. But generally speaking, 200 milligram per kg as the first dose. And then 6 to 12 hours later, you give 100 milligram per kg. Yeah?
Okay, sir. Yes, sir.
So have a look later. What is the strength of that? And you said the baby required second dose?
Yes, sir. The baby
Oh,
was given 2 doses.
okay. How many hours apart?
So 6 hours apart.
Okay, 6 hours apart. And what was the initial ventilatory settings, and how did the baby respond to the surfactant?
So after the initial surfactant, the
Or what was the ventilatory settings before surfactant, and what happened after surfactant?
So before after the first dose, the FiO2 requirement reduced to 35% from 50%, and after the second dose, we achieved around room air.
After the second dose, you achieved room air. And what was the ventilatory parameters? What mode of ventilators you were on at the time of
PTV
admission?
mode, sir.
PTV mode, okay.
PIP of around 22, PWEP was 5, and oxygen as I mentioned around 50%.
Okay. And what other parameters you can adjust on the ventilators?
So the respiratory rate
Uh,
and the inspiratory time.
okay. What were those? Do you have it in front of you?
So the respiratory rates we had kept around 40 at that time.
Okay.
Inspiratory time 0.35.
0.35. What are there is two things happening here, isn't it? One is oxygenation and another one is ventilation. Yeah.
Yes, yes,
So
sir.
now you go in the pressure, what you are delivering to the baby, and what would that have generated, and how much was that? You know what I mean? You are on a conventional ventilation, and you are on a pressure support here.
Yes, sir.
So, what is the important parameters for us to know when you are on a conventional ventilation with pressure support, which will guide us what could be the CO2?
So we can look at the chest rise of the baby to know if the ventilation is adequate, the pressure is
Okay.
adequate, and retractions. The baby has retractions, then that indicates we need to increase the PEEP further.
Okay. And what on the ventilator? What ventilator were you using, Draeger or SLE or other?
It's a Draeger ventilator.
Okay. And when you have got these sort of parameters, the ventilator would also show one more observation derived out of this. What is it called? It is the how much is the air going in and out?
So spontaneous effort will be shown, leak will be shown.
Yes.
If there is any air leak, then that also will be shown on the video.
Shown. So air leak will be shown. Yeah. Okay. And you are keeping this pressure 22/5 to deliver something. What is that called? tidal volume?
Yes, sir.
Okay. So what for in this conventional ventilation, what is the usual tidal volume you would aim to?
So 4 ml per kg.
Okay. In medicine there is always a range.
4 to 6 ml per kg, sir.
So 4 to 6 mils per kg. Okay. Yes. Do you know what it was delivering initially before surfactant?
No, sir.
No. I think because it's always important to think about the how much it's delivering the tidal volume. What is the problem? If I give a surfactant on a pressure support ventilation, and if I don't monitor some of these parameters, what can happen?
So pneumothorax can develop.
Okay, yes. Why pneumothorax can develop?
Because a sudden increase in pressure, an increased compliance, the sudden increase in compliance of the lung will occur, and if we keep delivering a high pressure, so it can lead to an air leak syndrome.
Okay, so good point. Because before you are given the surfactant, you needed a certain amount of pressure to get the tidal volume. But once you are given surfactant, then the compliance have improved and the tidal volume will increase. Yeah.
Yes, yes,
So
sir.
which means the chest might rise much more. So
Yes.
what parameters you can use to know what is the CO2 of the baby? What are the parameters which you can use to know the CO2 of the baby without doing a blood gas? I mean, these are all very extremely important, particularly as we look after the more and more sick babies and more preterm babies, isn't it?
So we can see if the baby has spontaneous breathing,
Okay, yeah.
because CO2 will trigger breathing, spontaneous breaths in the child.
Okay, so yeah, spontaneous breathing. If there is some CO2 buildup, the baby might start to breathe much more faster. Okay. What else will help you with your clinical examination based on the chest rise?
Yes, sir.
Okay, so based on the chest rise, you get a feel, how much pressure you would need because the chest is raised because of the tidal volume going in and out.
Yes, sir.
Okay, so chest rise. What other things you on the ventilator, which we just discussed now, would help you? Tidal volume.
Yes, sir.
Okay, so the higher the tidal volume, which means higher the minute ventilation, more CO2 clearance.
Yes, sir.
Okay.
Yes, sir.
So you need to closely monitor for the tidal volume, particularly after giving surfactant. If you are continuing with the pressure support, and what else you can use, which you can connect to a ET tube. You might have seen that in the PICU more than in NICU.
Cap. A flow
Capnograph
sensor.
gives the color change. Okay.
A flow sensor.
Flow sensor will help for the ventilator to trigger, to sense the baby is breathing, and it gives how much, the tidal volume. All of those flow sensor would help. But to know the CO2,
A capnometer, sir.
capnometer, okay, yeah. Even you can get a digital value. What is it called? Particularly as you are using for the at the end of the ET tube.
ETCO.
Okay, so you can use ETCO2. Yeah. Sometimes it's a bit hard with the 2.5 centimeters, 2.5 millimeters tube. What tube did this baby had? Size?
Size of the ET tube, sir?
Yes.
Sir, 2.5.
And how much was it at the lips if you would have done a oral intubation?
Sir, around between 6 and 6.5.
Okay. These are all some of the parameters which will need to be careful because you don't want to be too much in. But you told you have got the X-ray. Okay.
Yes.
Yes. Now, entitled CO2 is the other matter. But what was the other thing which you could consider if there was no leak? What is currently the evidence recommend to which form of ventilation the evidence recommend to use to reduce the trauma to the lungs on a ventilated babies?
So we can use volume targeted ventilation.
Okay, yeah. Was it considered?
Yes, sir.
And was there any problem with this baby? I'm generally asking, because it's also unit guidelines. I'm generally asking, what does evidence support? Volumes guarantee ventilation or pressure support ventilation?
So usually it is said whatever the unit is most comfortable with, that sort of ventilation is preferred.
Yes.
Uh, So in our unit, we usually go for pressure support, but volume is preferred.
Okay. Nowadays more and more evidence is supporting VG, but as you rightly said, it's also the unit what they are used to. But if something has to be changed in the unit, then we all need to work together, understand, and then make changes. Is that right?
Yes, sir.
But what are we trying to achieve by doing all this? What are we trying to reduce by keeping an optimal ventilation, minimal ventilation, appropriate oxygen? What are we trying to reduce the long-term complication?
So we're trying to reduce the development of BPD in the future by avoiding volume trauma, barotrauma to the lungs.
Okay, so the aim is, to reduce as much as possible air leaks and the long-term complications of BPD. Okay, so some of those things, that's what currently the recommendation is. And what is the recommendation of the PEEP? Do you know? Definitely not less than 4. Yeah.
Yes,
And
sir.
what is the upper limit?
So up to
Generally, the neonate limit. It's not evidence based, but most of the expert opinion sort of thing.
so 6 or 7 you can go up to.
Okay, and definitely not more than
7.
8. I don't know. They choose the even numbers. So
Okay.
8 is the 8. They tend not to go more than 8 for its own obvious reason. Because then you would have. How do you assess on the chest X-ray hyperexpansion?
So we count the number of ribs visible.
Okay.
Yes.
How much?
So 6 to 8 is ideal. If more than that is seen, then more than 9 are seen, then we consider hyperinflated lungs.
Okay. Anything else?
If it is hypolucent, or the heart is appearing quite small, the heart is squeezed.
Okay. So the heart, if it is looking more squeezed, okay, which means your mean airway pressure would be very high. Okay. Any other comment? Any other?
The intercostal spaces will increase, sir.
Okay. And also the diaphragm can become more flatter. Yeah.
Yes, sir.
More
Yes, sir.
flatter, and you can sometimes see, particularly on an oscillated babies, if the mean airway pressure is too high, you can see a bit of the bulging between the intercostal space. So it would be good to share in the presentation some X-rays from that point of view. Particularly for this baby, the X-ray would have been useful. And if this baby was not ventilated, you said about use of the oxygen as a guide. Yeah, for
Sorry, sir.
surfactant. If this baby was not ventilated
Yes.
and was on CPAP, if you would have admitted the baby on CPAP, let us say if it was a 26 plus week and you are admitted on CPAP, and then what are the parameters you would look for to whether the baby needs early surfactant or not?
So based on again the oxygen requirement and the pressure requirement of the baby.
Okay. So you
So
use more than 30% oxygen, yeah, with
yes,
adequate.
and a map of 7.
Okay, so if you're the baby, if you are on NIPPV, you consider MAP. Otherwise, it will be more of PEEP. That's what the
Yes.
machine would have
Yes.
given you, isn't it? Okay, yeah.
Yes.
Do you know any other things which people use?
Other than CPAP and NIPPV, sir.
No, the CPAP you said about the oxygen, and you said about the PEEP. You look at the baby's clinical parameters, yeah, work of breathing.
Yes, sir.
Okay. What are the parameters you look at while assessing the work of breathing clinically?
So we look at the chest rise.
Yeah.
We'll look for any retractions or nasal flaring.
Yeah.
Grunting or cyanosis would also indicate.
Okay. So if the baby is not saturating well, that would also help you. You said about use of accessory muscles, all of that, huh?
Yes, sir.
Including head bobbing, but also grunting. What does grunting means?
So grunting is expiring against a partially closed glottis. Uh, so the baby is requiring increased efforts to breathe,
Okay.
to make, so to generate PEEP and maintain the FRC.
Okay. Okay. So nowadays also, have you heard of ultrasounds in the role of this?
Yes, sir.
Okay. Okay. So again,
We perform lung ultrasounds in our unit.
so the team do perform lung ultrasound. So that's good. Did this baby in the course at any lung ultrasound?
Yes, sir.
Okay. Okay. Are you, from anything happening in the unit, it's always good to learn. So think about it. There is means of scoring of the lung ultrasound, and even if the baby was on CPAP, people can do ultrasound, score it, and then decide. Does it happen in the unit?
Yes, sir.
Okay. Okay. Now there was a echo done. What are clinical concerns you would have when you could request for an echo? What are the clinical concerns you generally have when you are requesting for echo, particularly?
So in preterm babies, um, we are worried about the PDA and
Clinically, what makes you think this baby could have had a good, PDA?
sir, if there's a poor circulation of feed intolerance that would point towards PDA.
Okay, so those could be some of the symptoms and signs. Any other things you would look out for in your clinical examination? You can hear me, Dr. Amita?
Yes, sir.
Yes. So some of the clinical parameters.
Uh,
Say you are worried about duct. Today it was day one. Either it could be day one or day 5. If there was no opportunity for somebody to do an echo on a
yes, sir.
routine basis, which happened for
Yes,
this baby, what are the
yes.
clinical parameters you would pick up and say, oh, it would be better to do an echo to assess PDA?
Sir, the baby had a high FiO2 requirement, or
Okay.
the urine output was decreased,
Okay.
or if the baby had a feed intolerance,
Okay.
then we should consider an echo.
Okay. And in terms of your examination, anything? Clinical examination?
Based on the pulses of the baby, bounding pulses would indicate the need.
Okay. Yes. Yeah. Anything else?
Any signs of a hyperdynamic circulation?
Good. Okay, so you need to think about an hyperdynamic circulation, and so the baby could be tachycardic, tachypneic. All of the one is primarily related to the heart, but you also need to think what you explained more is related to the other end organ perfusion problems, but also to
Yes.
think of the primary and most common symptom would be tachycardia, tachypnea, as you said, increasing oxygen requirement, increasing respiratory support if the baby is on the ventilator. Huh? And then you said about feed intolerance. And then you examine the baby, you will have an active precardium. Yeah.
Yes, sir.
And you feel the pulses, they are bounding. Why they are bounding pulses?
So because of the increased blood,
You
increased
get
blood flowing into the system because of the shunt.
because of the shunt. So you get a high systolic and you could have a low diastolic. So the pulse pressure will widen.
Yes, sir.
So that's the reason you feel the pulses as bounding. Okay. And even you can feel all the small peripheral arterial pulsations as well because of the bounding nature of that one. Okay. So now this baby did not need any treatment because the duct was already restrictive. from
Yes.
day one.
Manju,
So,
sorry to interrupt, Manju. I think we have now few minutes to go. Actually, we just need to
another
finish
5-10
before
minutes,
3.
huh?
Yeah, 5 minutes. Yeah, if
Okay.
possible.
Just
Thank you.
in terms of the nutrition,
Yes, sir.
you said about this was a very good demonstration of early nutrition and full feeds by day 7 of life.
Yes,
Yeah.
sir. Yes, sir.
Tell me some of the complications. Fortunately, this baby has done really well from
Yes,
that
sir.
point of view. What are some of the complications
So
of being born
NEC can
extremely?
develop necrotizing enterocolitis,
Yeah.
and sepsis can also develop. Feed intolerance can occur.
Feed intolerance. One of the main thing which was missing, I was about ROP screening. Did you mention about that?
Uh, no, sir, I did not mention, but ROP screening was done at 28 days of life.
28 days of life. Okay. Do you know what is the recommendation? When does these babies needs to have the ROP screening?
So in ELBW babies at around 30 weeks, we should do the first screen. 3 weeks.
Check.
3 weeks after in ELBW babies, sir, after 3 weeks.
Oh yes, its recommendation is 2 to 4 weeks because nobody should be missing as much as possible, and there are few medical legal cases regarding the missed opportunities. What are we trying to look into?
So we look at the vascularity of the retina in these cases and how far it has progressed.
Okay, okay, and we don't want to miss any significant ROP. I think it's good to read about ROP, and some of the other complications are extrauterine growth restriction. But this baby has been doing well from that point of view. Yeah.
Yes, sir.
So you said the head scans were normal. Is that right?
Yes, sir.
And when does the bleed happen generally? Do you know intracranial bleeds? At what age?
In the first 24 hours,
Yes, most of
around
them.
50% of bleeds develop in the first 24 hours.
Yes, and after 72 hours, it becomes much less and less. But it was good to think about it because you said the hemoglobin was low on day
Yes,
14 or 15, and you thought as anemia of prematurity and transfuse, but you did look for any other causes for anemia from that point of view. Okay, yes, yeah.
yes, sir.
I think this is a big topic, but time is always short to discuss. And KMC was happening regularly. What is your unit policy?
Yes, sir.
Okay,
The
okay,
mother was coming for KMs.
okay, okay. So, and all of that was mother's milk, as you said. Huh?
Yes, sir. Currently the baby is on completely on mother's milk.
Okay, okay, okay. How many? Maybe 1 or 2 minutes more. And this baby was not positive with any blood culture at any
No,
point of
sir.
time, or no
No,
raise
sir.
in inflammatory markers.
No, sir.
Okay, okay, okay. Good. So this was a good example of extreme preterm baby. Yeah. And have you heard of any care bundles to prevent some of the complications?
Uh, when a VAP bundle,
Okay.
developmentally supportive care,
Neurodevelopmental care bundle. Okay. Yeah.
and CLAPSI.
Okay. So I think good to think about some of those, and this baby has been, has done really well, and also particularly for being born outside. Yeah.
Yes, sir. Yes, sir.
Okay. Okay. Yes.
Yes,
Thank you, Dr. Vishal. If you feel the time is up, I'll stop there.
Yeah, thank you so much. I think it was a nice, healthy discussion. I think, and Amita presented very well. And I think you cover all the parts, about the extreme preterm. Of course, it is a little bit, challenging to manage this 24-weeker, 25-weeker baby, and we need to focus all aspect of the system, including not only the respiratory, but I think we nicely cover.
Thank
So I think thank you so much, Manju, again the accepting our invitation in short notice, and we definitely will take advantage of you. Amita, you did very well, and I think you present the things. And of course, as a fellow, sometimes we could not, difficult to manage the preterm baby, but I know the team. The unit you are working there excellent in managing this kind of preterm baby. So thank you so much. I
And
think
Vishal,
yes,
yes.
please.
Thank you, Dr. Amita. Thank you. It was a nice presentation. Well done. Fluency was good and it was thorough. But these babies will have a 40, 50 days history, and it's always a challenge to bring up everything. But you did really well from that point of view. And Dr. Vishal, thank you for having me, and also Dr. Kunal, thank you. I'm sure we'll cross each other soon. And Vishal and I spent just for my your other colleagues had a very great time in Plymouth in
Yeah.
army course. And Vishal was also kind enough to come to Bangalore for to join us for
Hemodynamic workshop. Yeah.
hemodynamic workshop, so we could spend more time. Thank you. Looking forward to meet you all again. Thank you.
Thank you so much. Thank you so much.
Thank you so
Shreyanshi, you
much,
can
sir.
now, sorry, Amita, are you just something, do you want to speak anything, Amita?
So just thank you so much, everyone.
Welcome.
Yeah,
Welcome.
thank
Thank
you.
you, Amita.
Welcome. Shreyanshi, you now conclude the session and we can now stop sharing the things.
Thank you, sir. Thank you so much, everyone, for giving us the opportunity to host this session today. Thank you. Have a good day to
Thank
all
you
of
so
you.
much. Bye.
Thank